We are currently working in the management phase of Mrs. Tubbs' mechanical ventilation. While patients are on the ventilator, we like to get frequent arterial blood gases on them so that we can keep an eye on their acid-base balance and make sure that no ventilator changes need to be made. Because Mrs. Tubbs does have COPD, her ABG values will be slightly different than a person without COPD. These are the normal values for a patient with COPD. The pH is 7.34 to 7.37. The PaCO2 is 55 to 65. The bicarb, or HCO3, is 28 to 34, and the PaO2 is 55 to 65. The pH is naturally acidic because the CO2 is slightly elevated. To balance that all out, the bicarb is slightly elevated also. It's important that a patient with COPD has a lower PaO2 than a person without, because if you give them too much oxygen, their drive to breathe will be knocked out and they'll become obtunded. So it's important to keep an eye on these values. While we are progressing towards weaning, I will keep a special eye on things such as Mrs. Tubbs' spontaneous volumes. I'll monitor her heart rate, her oxygen saturation, make sure that she's not getting too anxious, talk to her, let her know what's happening. It's also important that you communicate with the nurse to make sure that their sedation levels are lowered or turned off. You want to make sure that your patient can respond to you and follow commands.
Mrs. Tubbs' vital signs have been stable and normal for her age and cardiopulmonary disease status. Her oxygen saturation is 91%, which is good, and her attending physician, Dr. Nose, has asked that I wean her down to minimal settings on the ventilator and put her at an SIMV rate of 4, which will mean that she will be receiving 4 breaths from the ventilator. He's done this especially because of her COPD. Mrs. Tubbs is currently set at a frequency of 10. Her attending physician, Dr. Nose, has asked that I bring her down to a rate of 4. I will not immediately drop her to 4. I would take her down to 6 by highlighting this and then using this knob to adjust it and hitting accept when my changes are final. After 30 minutes after making a vent change, I would draw an ABG to make sure that Mrs. Tubbs' acid-base balance is good and that she's ventilating well. Because Mrs. Tubbs is already set on minimal ventilator settings with an FiO2 of 35, pressure support of 5, and a PEEP of 5, I will not manipulate these settings unless she goes into distress. I may need to bump her oxygen up a little bit. I will assess her oxygenation invasively with an ABG. I will do the same to assess her ventilation invasively. I can assess her oxygenation non-invasively using her pulse oximeter, and I can assess her CO2 non-invasively with the detector attached to her ET tube. While we are making those vent changes, I can use other patient assessment skills. I'll need to make sure that her oxygen saturation stays up, that her respiratory rate does not increase, as well as her heart rate and her blood pressure. These are signs that she's getting anxious.